I've never been here, and it's a real pleasure to do that. So let's see. Whoops. Do I need a... Oh, there we go. It's just, these are my disclosures. And this is what I want to talk about today. I want to take you through a little bit of a tour de force through first-line therapy. And then talk a little bit about what are we going to do if that doesn't work. And I would also like a little bit about how we integrate other treatment options than systemic therapy into our overall management. So when we look at kidney cancer, over the last 20 years, a lot has happened. We went from virtually having nothing for 75% of our patients to now having 4 combinations that all have shown an overall survival benefit over the old standard sunitinib. That's dual immunotherapy with nivolumab and ipilimumab, and then 3 IO TKI studies, pembrolizumab, axitinib, nivolumab, cabozantinib, and pembrolizumab plus lenvatinib. And more recently, we've seen the first results of a triplet combination, which I would also like to briefly talk about, because I think that is a concept that needs to be considered at the moment very carefully. But it is something that we've always naturally done in oncology. If you have an active drug A and an active drug B, you put them together, and then you have an active drug C, and you create a triplet, hoping that the triplet would be significantly better than what you had before. Now, when we look at the impact of the last 20 years, we see here that before we had targeted therapies, the median survival for metastatic kidney cancer patients was approximately a year. With targeted agents, TKIs, we doubled that. And now with the introduction of immunotherapy, we doubled that again. And I have to say that is something that is very, very significant. I started doing work in kidney cancer when we had interferon and interleukin. It was a pretty desperate field. And now we have a variety of different treatment options, and we can keep patients alive with a good quality of life for a lot longer. So this is one of my patients, 66 years old, history of gross hematuria. A CT scan revealed a large kidney mass, multiple pulmonary metastases. Based on the IMDC criteria, he was an intermediate patient with 2 risk factors. And the question in a patient like that is, how do you best treat a patient like that? Do you give him dual immunotherapy? Do you give him IO TKI? Or is that potentially a patient for triplet? So let me take you through that. What is the data for those different regimens, and what do we or I consider when I think about a patient and how to make a choice for one regimen or the other? So these are the studies we have. I already alluded to them. Checkmate 214 is the dual immunotherapy study, and then we have the 3 IO TKI studies as discussed before. So what are the results with that? When we look at the dual immunotherapy trial, and that is the trial with the longest follow-up, the latest follow-up that was reported has a follow-up of more than 5 years. There will, in the very near future, be another 7-year follow-up, which will be very interesting to see. And what you see here is that there was a clear-cut overall survival benefit, median survival for all patients in that study, and all these patients were intermediate and poor risk, was 47 months versus 26 with sunitinib. The 26 with sunitinib is pretty much exactly what you would expect from sunitinib. Sunitinib performed as expected. And then you have the PFS, which is not as impressive. There's only a 3 months median PFS benefit, but you can see that in the long term, the curves start to split wider. And there's even seems to be this plateau there, which I will talk about in a second again. When we look at the IO TKI combinations, pembrolizumab plus axitinib you see here the progression-free survival, and this is also an updated analysis with a median follow-up of also 67 months. You see that the benefit is maintained over time, about 16 months versus 11 in terms of PFS, but we don't see really the same kind of elevated plateau as we saw with dual immunotherapy. And there's an overall survival benefit as well, with a very similar overall survival of about 47 months. Checkmate 9ER combined nivolumab plus cabozantinib, again, compared to sunitinib. 44-month survival, median follow-up, and we see a very similar picture to what we've seen with pembrolizumab and axitinib, a significant PFS benefit, a significant overall survival benefit, all in the range, similar range, what we've already seen with the other two regimens. And last but not least, pembrolizumab plus lenvatinib, which was just recommended for funding in Canada, in BC. We can access that since September 1st as an alternative to pembrolizumab and axitinib. And just by numbers, this is the study with the longest PFS, 24 months, versus sunitinib 9 months, and with a 54-month median overall survival across all IMDC subgroups. Now, when we look at that, is there really a preferred regimen with IO and TKI? I personally don't think so. I think in the absence of a clear-cut comparison that would show that one is better than the other, I think they're all relatively similar. As I mentioned, nominally, pembrolizumab plus lenvatinib has the best numbers, with 70% response rate and about an 18% complete response rate. What is remarkable for these regimens is that they all have a very low primary progressive disease rate. It's less than 10%. With nivolumab and ipilimumab, it's about 20%. And that results in a very high disease control rate. What is also a difference to nivolumab and ipilimumab is that the median duration of response has been reached and is somewhere between 23 and 27 months. Now, the question, of course, becomes, what is the optimal benefit for our individual patients? And of course, optimal benefit is a therapy that maximizes the benefit and minimizes the risk. And we can measure benefit in different ways. We can define it by tumor shrinkage, long-term survival, progression-free survival. Risk is usually synonymous with toxicity, but there are other things like how much therapy hassle is there for the patient, how much financial toxicity. And the question is, what factors should we consider when we choose first-line therapy, and how do we make that decision when we talk to our patients? And I would say the short answer is it really depends on how you look at things and what you and your patient value most in terms of outcomes. Now, it's not overall survival because when you look, this is just a comparison of all the overall survivals in the studies we have. And as you can see, the relative benefit seems to be very similar from one regimen to the other. They all have a hazard ratio of about 0.7 to 0.8. And while the IO-TKI regimens initially reported very favorable hazard ratios with 0.5 and 0.6, they all have increased over the follow-up period. And it seems to be that the relative benefit is very similar across these different regimens. So just a survival benefit is not really a good differentiator in terms of how we approach these patients. Of course, ideally, when we talk about choosing the right regimen, the best would be to have a predictive biomarker, something that we can measure that would tell us what the chances of a patient is to respond or not to respond. And unfortunately, in kidney cancer, it doesn't seem, first of all, we do not have anything. We don't have anything that is ready to be used in clinic. There are some small trials that are attempting right now to use potential biomarkers, but we have not really seen any convincing results. And it seems to be a lot more complex than in other diseases, because in kidney cancer, we have not yet found any classic biomarkers such as ALK or EGFR in lung cancer or HER2 in breast cancer. Kidney cancer doesn't seem to have that, or at least we have not found it yet. So it's not as easy here to really define a predictive biomarker that would clear-cut help us in making treatment decisions. So the question is, what factors might impact the choice of treatment? And there's a variety of different endpoints that we can think of that are potentially important. Overall response rate, progression-free survival, overall survival, duration of response, long-term survival. And the question is, how does the hierarchy of these endpoints impact your choice of treatment? And how does potentially the patient's presentation impact the hierarchy of endpoints? Depending on the presentation of the patient, may one objective be more important than the other? How about the short-term versus long-term benefit? And then very important, of course, what do our patients want? And that is something which we actually have now seen data for, because Casey Cure, the American Patient Support Group, actually conducted a study among their constituents and asked the question, what is most important for you when you start treatment for metastatic kidney cancer? And the overwhelming majority of patients chose chance of eliminating all evidence of disease and durability, which patients really use synonymous with cure. For patients, the disappearance of all tumor is I'm cured. So that is what patients really strive for the most. Quality of life, also important, low risk of toxicity. And the last patients seem to really bother is the cost of treatment. So when we look at the different options we have, dual immunotherapy versus IO-TKI, what are the differences in terms of detailed outcomes that could potentially impact how we use these regimens? When we look at response rate, we see that IO-TKI regimens in general have a significantly higher response rate than dual immunotherapy. About 60 to 70% response rate for the IO-TKI combination, about 40% for nivolumab and ipilimumab, about a similar complete response rate, 12 to 16%. But there is a difference in primary progressive disease rate. When we look at the IO-TKI regimens, primary progressive disease rate, so progressive disease as best response, aka patients are simply, the tumor continues to grow through treatment, 6 to 10%. For nivolumab and ipilimumab, about 20%. So there seems to be a much higher disease control rate for IO-TKI regimens. How about PFS? When we look at PFS, we see that all IO-TKI regimens have a very decent PFS benefit in the range of about 4 to 6 months in median. And the benefit seems to be maintained over time. But what we don't see here is a similar development of a plateau as you see here with nivolumab and ipilimumab. And keep in mind, after 5 years, about 30% of patients on nivolumab and ipilimumab remained progression-free while being on that drug or being off the drug. So durability of responses is another important factor. When we look at that, we see that the duration of response has been reached, as I mentioned, for all the IO-TKI regimens. And the duration of response was somewhere between 20 and 26 months. When we look at the latest report on nivolumab and ipilimumab, we see that a lot of these responses seem to be durable. And the median duration of response actually has not been reached yet. More than 50% of responses seem to be durable and ongoing. About 80% of complete responses were still in complete response after 5 years, and about 60% of partial responses, with about 40% of these patients being off all treatment. And when we look at the curve here, it starts at about 24 months. And why is that important? Because when we go back in time, when we used high-dose interleukin was a treatment that was very toxic, and the majority of patients did not benefit from it. But there was probably about an 8 to 10% group of patients that had a very good response to high-dose IL-2, and there were patients who were cured. And when we look at their probability of continued response, you see that the patients who remained in response after 2 years, after the 24 months, they seem to have an excellent chance to maintain their response long-term. And this is exactly the picture that we see with the ipilimumab and nivolumab response curve that I just showed you. So there's hope that those patients who have a very good response to dual immunotherapy hopefully have a response that is lasting and going on. So how do we put that all together? So if a patient really puts the emphasis on long-term survival, if you have a patient that is not overly symptomatic, where you know that even if the patient progresses on first-line treatment, you can have second-line treatment, then an IO-IO regimen is probably the best of your choice, because it has this potential for long-term response if the patient tolerates it and has a good response. On the other hand, if you have patients that are very sick, and we all have these patients, they come in with poor risk criteria, they are very symptomatic, and you really are concerned that if the patient continues to progress, then you may not get a chance to give him any other therapy, then there may be a benefit for an IO-TKI regimen because they have a higher response rate and a higher tumor control rate. And in these patients where response rate is everything, it may be a good idea to use an IO-TKI regimen in order to get that tumor under control and hopefully be able to improve the condition of the patient. Now, we gave our patient dual immunotherapy, and he tolerated that very well. And you can see after about a total treatment of 7 months, the induction therapy plus about 4 months of maintenance, he had almost a complete response in the lung, with most of the metastases disappeared, a couple of small residual things, but he still had this rather large primary tumor. And the question is, in a situation like that, what is the best way to deal with that? Do you just continue systemic therapy, or do you potentially put something else in the mix? And the something else is obviously a local treatment option. Can we utilize cytoreductive nephrectomy? And I don't want to go into all the details about cytoreductive nephrectomy, but I want to talk about this particular aspect of a delayed nephrectomy. And then we have other means such as stereotactic radiation that we now can utilize. So what we know from all the studies, and this is just the dual immunotherapy study, but it's the same picture for all combinations. We know, because the results have been reported, that if a patient has his kidney tumor in situ, they will have a similar benefit than patients who do not have the kidney and had the kidney out. But absolutely speaking, the benefit is a lot less. So patients with a primary tumor in situ don't do as well as patients without their primary tumor in situ. And keep in mind, I think it's still correct to say that you will almost never see a complete response in a primary kidney tumor. They just don't respond the same way metastases respond. So it's an important question to ask: if perhaps a patient has a good response in metastatic sites, what are we going to do with the primary tumor? And we have some data from the TKI era. This is the data from when we treated patients with TKIs. And this is a study from the IMDC database. When we took the kidney out in a delayed fashion in patients who had a very good response to TKIs, there seemed to be a benefit for these patients. And that was also seen in the Carmina trial, which was basically a trial that looked at a randomization between patients to have a nephrectomy and then sunitinib versus only sunitinib. And on the sunitinib arm, there were a number of patients who had a nephrectomy down the road, either because they had a good response or they needed it for local symptoms. And as you can see here, that seemed to be associated with a very good benefit, which is not surprising because you positively select a patient population when you do that. There was also a trial that looked at the question of upfront or delayed nephrectomy, the SURTIME trial. And unfortunately, that trial did not recruit very well and was prematurely closed. But when they looked at the number of patients they had, they also showed that there was a benefit in taking the kidney out in a deferred fashion if patients had a response to treatment. And more recently, and this is the first data from the immunotherapy era, there was a study published at ASCO GU where a group looked at their patients who had a good response with immunotherapy, and they looked at, if we use local treatment options, can we increase the number of patients who have a complete response? And as you can see here, there seemed to be a significant portion of patients that could be rendered disease-free. A significant portion of those patients subsequently discontinued treatment, and the majority of them, at least for now, has been staying and remaining in remission. So I think it is extremely important that when we have these patients at various time points, we think about how can we potentially include these local treatment options into our treatment. So we did that with our patient. We asked our urologic surgeons to take the kidney out. The kidney showed mostly necrosis, but there were some remaining tumor cells left. And the patient has been in remission since. So he has been now for 4 years in complete remission. The last year without any treatment because he decided last year to come off nivolumab maintenance therapy. and he's doing extremely well. As I mentioned, stereotactic radiation is another excellent tool. Kidney cancer for the longest time was considered a radio-resistant disease. Before we had stereotactic radiation, if you radiated a kidney cancer metastasis, you probably could keep it under control for 6 to 9 months, and then they started to progress. It was a pretty depressing issue. And then stereotactic radiation came along, and I think it's really a game changer, because I've had now many patients who had stereotactically radiated brain metastasis or bone metastasis, and they remain in remission for a long time. This is just an example of one of my patients who had lung metastasis, and we treated him and he had a good response. But then about 6 months into his treatment, he developed this solitary metastasis here, as you can see and here. And that was treated with SBRT, and the patient has never had any progression in that site. If that has been radiated with regular old-fashioned conventional radiotherapy, the patient would probably have progressed about 8 or 9 months later. So I think it is very important that we consider that, particularly if we have a situation where the majority of the tumor is under control and only a small portion of, only 1 or 2 tumor sites start to progress, this concept of oligoprogression, where we can then try to introduce local treatment options to extend the patient's time on therapy. And there is now an increasing body of data that shows that that actually works. And a good portion of patients has an extremely good benefit of that. So in the overall management algorithm, it's systemic therapy and as well local treatment options that we can use. Now, obviously, the next step would have been, okay, if immunotherapy, double immunotherapy has good long-term outcomes and IO-TKI regimens have good short-term outcomes, why don't we just combine them and we get the best of both worlds? And that's why triple regimens are now under investigation. And this is the first one that has actually been reported. And that's a combination of cabozantinib, nivolumab plus ipilimumab. And this is also the first study, randomized study, that had a modern control arm with nivolumab and ipilimumab. And that is an interesting study because we can learn a lot from it. These are the results. So first, what we see is there's not a massive difference between the 2 regimens in terms of overall response rate, which I think is the first surprise. You would have expected the TKI containing combination to be a lot better. There was a benefit, but not massive. There were relatively few complete responses, which could have to do with the fact that this study had a comparatively speaking large portion of patients that did not have their kidney out before they metastasized. So only about 60% of patients in this study had a prior nephrectomy. And when we look at the progression-free survival, there's a modest benefit with about a 4-month PFS benefit. So the question is that something that we should use? Is something like that ready for prime time? When we look more closer, it seems that in particular the intermediate group, so just about the group of patients where the case I presented falls into, that the intermediate group seemed to be responsible for that PFS benefit, which is a bit of a surprise because you would argue the worst patients should probably have the biggest benefit, and those would be the poor risk patients. But they didn't in that study. And the question is why, and what are we going to do with this? And of course, the biggest question is, how do we interpret these responses? And when we look at that, yes, we had more responses in the triplet therapy arm, but the responses were not as deep. And why is that important? Because we've shown for all of these studies, whether it's any of the IO-TKI studies or the dual immunotherapy study, that the depth of response correlates with survival. The better your response, the longer the patient lives. And if you have to trade a slightly higher response rate, but you get less deep responses, you probably get less good results in the long term. And the question, of course, is, how about overall survival? Will a triplet really improve overall survival? Because if you combine these drugs and you expose the patient to the cost of that, in particular in terms of toxicity, then you really want a good benefit over a sequence of things. And the big problem here seems to be toxicity. When you put all these drugs together, there's a lot of overlapping toxicity, skin toxicity, GI toxicity, liver toxicity. And cabozantinib is probably the most unfavorable partner to partner with immunotherapy because it has the longest, by far the longest half-life, which means if you have a toxicity, it goes on for a long time and before it gets better. And that probably explains to a large part the problems we see here. And what we see here is that the daily average dose of cabozantinib in that triplet combination was only about 20 milligrams, which is basically the lowest carbo dose we use. Only about 55% of patients received all induction doses of ipilimumab. A large majority of patients needed dose reductions, and a significant portion of patients discontinued any or all of the study medications. And a whooping 60% of patients needed high-dose steroids. Why is that? Well, because if you have a patient who develops liver toxicity on cabozantinib plus nivolumab, ipilimumab, you cannot wait to find out which of the two drugs actually causes it. Cabozantinib has a half-life of about a week, and you cannot wait for a week without treating the patient to find out whether it gets better if you stop the cabozantinib. So I think a lot of these patients were started on high-dose steroids simply because the treating physicians couldn't be sure whether it's an immunotherapy effect or whether it's a TKI effect. What is also not good about that is obviously because there are reports suggesting that if you have to put a patient on high-dose steroids, that the immunotherapy may not be as effective if it's not. So why is that important if we give a lower dose of a TKI? Because we know, and this is very old data, we know that there's a certain dose response relationship. You need a certain exposure to the drug in order to have the highest possible benefit. And that is a concept that is unfortunately a little bit forgotten these days in the era of combination therapies, but it is extremely important that we maximize the benefit of our TKI. And when you have a regimen like pembrolizumab plus axitinib, I see a lot of patients who get started on 5 milligram axitinib BID, and then nothing ever happens, irrespective of what their toxicity is. And a lot of physicians forget that they need to adjust the TKI based on toxicity. And this is a concept that obviously Georg had the largest input in, this concept of dose schedule individualization. And I would really urge people that this is a concept that applies to each and every one of the tyrosine kinase inhibitors we use, whether it's sunitinib, pazopanib, or cabozantinib. And you have to do it with each and every one to really get the best benefit from your TKI component or from your single agent TKI in order to do that. And I think the Canadian prospective phase 2 study, which was led by Georg and developed by Georg, is probably to date the study which showed the best outcomes for single agent sunitinib that was ever reported. Why is it important that patients get their induction with immunotherapy with ipilimumab? Because there's good data in melanoma suggesting that this initial immune burst, this initial stimulation of the immune system, probably carries a large part of the immunotherapy, the ongoing immunotherapy response. And if you don't have that, then your immunotherapy may not work as well. And there's some data suggesting that this may be very similar in kidney cancer. This is a very good editorial from Jason Luke about melanoma studies. And what he basically looked at was, he looked at the studies which had this initial concentrated dual immunotherapy induction versus studies that did not have that. And he clearly could show that the studies who did have that seemed to be superior in terms of survival than the studies who did not. So I think if you give immunotherapy, dual immunotherapy, it's important to give it early, and you have to give the induction in the beginning in order to get that best benefit from it. So in conclusion, in first line, I think we now have 4 regimens that have shown an improved survival. And it really depends on how you and your patient looks at the data and what you think is most important in order to choose the right regimen for the individual patient. I usually choose an IO TKI if I have a patient where response rate is the most important goal, because the patient otherwise may not be able to get any further treatment. But in the majority of patients where we don't have that, and in patients who really look for a long-term benefit, dual immunotherapy seems to be the way to go. I don't think triplet therapy has shown any convincing data yet. I think it's not ready for prime time. Biomarker decision-making remains elusive. And I think it is important that we integrate local treatment options at the right time to improve and maximize the benefit for our patients. Now, what is going on? There's a number of different studies ongoing. Other triplet therapies, as you can see here, with lenvatinib, pembrolizumab, and belzutifan, with lenvatinib and pembrolizumab and quanolimab, which is another CTLA-4 inhibitor. So we will see what comes from these triplet therapies in the future. There's also studies ongoing, like the one on the bottom, where you start everybody on dual immunotherapy. And if they have a good response, they continue with maintenance. If they progress, they get a second-line treatment. And any patient in between with an insufficient response gets either randomized to maintenance or the addition of a TKI. We will see whether that really does a lot. My personal opinion is that you can probably right now sequence and combine our current toolbox any way you want. I don't think that we will get a major step forward out of it. I think we've hit a wall with the drugs we have, and whether triplets will improve that or not, we will see. But I think we need new ideas and new drugs and new different things in order to really make the next big step. So what do we do if these first-line regimens fail, despite their good outcomes? We can move them to second-line treatment. What is important to keep in mind when we do that is that every time we switch line of therapy, we have a drop-off in patients. Not every patient who gets first-line therapy gets second-line therapy, and not every patient who gets second-line therapy gets third-line therapy. And I think we all tend to overestimate the number of patients we move to the next line of therapy. So it is something really to be conscious about, because it requires a certain level of vigilance to make sure that you switch your patient early enough that they can get to the next line of therapy. And because we spent 10 years on trying to figure out how to best sequence drugs in the TKI era, when immunotherapy combinations came along and changed the whole first-line picture, we basically were left in the dark with regards to what's the best sequencing strategy. And really today, if you have a first-line combination, you can choose a second-line TKI, and then in third line, you can choose another TKI. But the optimal sequence has yet to be defined. What is data that we use for our current strategies that we do? We use cabozantinib a lot. At least in BC, it's the standard of an IO-TKI combination. We cannot immediately access it after IO-IO, although there is now an increasing body of data that clearly shows that cabozantinib is very active there as well. This is the Cabo Point study, which is a France-led study from Europe, which looked at cabozantinib after IO-TKI and after IO-IO. And as you can see here, it seems that cabozantinib is quite active irrespective of what the prior treatment was, whether it's IO-IO or dual immunotherapy. A very good overall response rate with even some complete responses. And Cabo-Sec was a study that was published just at ESMO about a week and a half ago. And what the investigators did here, they took data from the IMDC database and basically did what is called a target trial emulation. It's basically a simulation of a randomized trial. And they looked at cabozantinib versus sunitinib. And of course, this is all retrospective data with all its limitations, but the totality of the evidence goes all in the same direction. In this Cabo-Sec study, again, they showed that cabozantinib seemed to be better than other TKIs that we have in the post-IO-IO space. Now, ultimately, the only response, whether that's true or not, would be a randomized trial. But unfortunately, I don't think that will ever be done. So we have to deal with what we have. Another big question is, of course, now that we have different immunotherapy agents, can we sequence immunotherapy agents? So if the patient had an immunotherapy combination in the first line, does it make sense to give him another one in the second or third line? And initial reports of retrospective data seem to suggest that, yes, there may be some benefit. And just recently, the first randomized study read out at ASCO of this year, which was the CONTACT-03 study, which was a study of atezolizumab, a PD-L1 inhibitor plus cabozantinib versus cabozantinib in patients who had prior exposure to a immune checkpoint inhibitor. And this is specific for that study. the study required the patient to have had a checkpoint inhibitor in the immediately preceding line of therapy. That's important to keep in mind when we talk about the results, because the results were absolutely negative. There was no benefit for the addition of atezolizumab to cabozantinib in terms of PFS or OS. I think what the study shows is that cabozantinib is very active in that space, but the addition of atezolizumab did not improve outcomes. It did increase toxicity, but it did not improve PFS, it did not improve overall survival, and it did not improve complete response rate. So the question is, what does that mean? I think it's probably relatively safe to say that if a patient has progressed on a PD-1 inhibitor, to immediately give him another immunotherapy does not work well. It does also not work well with ipilimumab. We have seen that data. There's 2 or 3 studies that have looked at what happens if a patient does not have a good response or progresses on a PD-1 inhibitor. If we give them ipilimumab on top of it, does that help? It doesn't seem to work very well. What the study does not answer is the question of what happens if we give somebody first-line immunotherapy, then we give him something else, a TKI, and then we give him immunotherapy again. Is that a concept that could potentially work? We don't know, but there are studies underway that will probably answer that question in the very near future. And what was also shown at ESMO was the long-awaited LIGHTSPARK-005 study, which looked at belzutifan versus everolimus. Now, these were patients who had 1, 2, 3 prior lines of therapy, and all patients had to have at least 1 tyrosine kinase inhibitor and 1 immune checkpoint inhibitor. So relatively heavily pretreated patient. What is belzutifan? Belzutifan is a HIF-2 alpha inhibitor. HIF-2 alpha plays a crucial role in the angiogenesis pathway and creates a transcription factor. For the longest time, it was thought that that mechanism cannot be blocked, but belzutifan is now the first drug that actually does that. There are others in development. And the drug was initially used in VHL patients, von Hippel-Lindau patients, who have a genetic defect that leads to the formation of tumors and kidney cancer. And the underlying problem there is the defect in the VHL gene. And belzutifan showed good activity there. And because the majority of clear cell kidney cancers mimic a similar mechanism, it was also tested in early studies in kidney cancer and showed responses there. So that's the rationale for this phase 3 study. And this is the primary endpoint, progression-free survival. You see there was a statistically significant benefit in terms of hazard ratio. The median PFS was actually virtually the same. But you see here from the PFS curve that there's obviously a group of patients that seem to have a very prolonged benefit with that drug. From personal experience, the very first patient I ever treated with belzutifan was my first patient I put on this study. And the patient was a third-line patient, had an immune checkpoint, had a dual immunotherapy initially, then had second-line TKI. And he went into a complete remission that is now ongoing for close to 2 years. Now, that's maybe an exception, but it clearly shows the drug is active. And the PFS curve suggests that there is a certain group of patients that seem to have a very good benefit. The overall survival is not mature yet and has not shown any significant benefit yet, but there was also a significant benefit in terms of response rate and in particular in duration of response. So the patients who seem to respond to that drug seem to have a good response and a durable response, and that explains the difference in PFS. So I hope that belzutifan will come our way in the not too distant future, because it could fill that gap that we have right now in our treatment as a second and third line and fourth line treatment for patients who are still fit enough. And we have now many of those where we don't have any funded option anymore. Belzutifan is relatively well tolerated. 2 key side effects are anemia and hypoxia. They are explained through the mechanism of belzutifan, but they can actually be relatively well managed. Anemia can be managed with transfusions. Some physicians give patients low doses of erythropoietin because belzutifan leads to a decrease in naturally produced erythropoietin. Hypoxia can respond to oxygen, but the majority of patients tolerates that extremely well. And otherwise, it does not seem to have a lot of the classic TKI side effects, such as hypertension, hand-foot syndrome, or things like that. So it's relatively well tolerated. There's a number of studies ongoing in the second-line space. Tivozanib plus nivolumab versus tivozanib is one of those studies that will hopefully answer the question, what happens if you sequence something between immunotherapy exposure? Because this is a study that also looked at patients who had prior immunotherapy, but they did not require the immunotherapy to be part of the immediately preceding therapy regimen. And then we have new combinations such as belzutifan plus lenvatinib. That was also a study in patients who previously had been exposed to checkpoint inhibitors. And that was tested versus cabozantinib. That study has completed accrual, and we will hopefully have results within the next 1 or 2 years. So in conclusion, I think we have active second and third line agents. Cabozantinib is one of them, seems to be active irrespective of what you give in first line. I think the addition of another immune checkpoint inhibitor after progression on a first checkpoint inhibitor is not really a concept that is in any way ready. It does not seem to confer a good benefit. And I think belzutifan is a novel option that we will hopefully get, because there seems to be a group of patients that has a very good benefit from that drug. With that, thank you very much, and I'm more than happy to take questions.
Thank you, Dr.